Good morning. Thanks for joining us right on time. We're going to wait just another couple of minutes to let some more folks log on, and we'll begin the webinar shortly. Good morning. I'm Amy Rowley McGee, the president of the Health Policy Institute of Ohio. Thank you for joining us for our online forum today, What's on the Horizon for State Health Policy? Improving the Health and Well-Being of Older Ohioans. The mission of HPIO is to provide the independent and nonpartisan analysis needed to create evidence-informed state health policy. I want to thank our core funders who advance our mission through their steadfast investments in our work. I also want to thank the Cardinal Health Foundation, our presenting sponsor for our forum series, as well as all of our 2020 Forum Series sponsors for their generous support of our online Forum Series. We encourage you to tweet throughout today's webinar using the hashtag HPIO Forum. If you have any questions for any of the presenters, please type them into the question box, and then we will pause after each presenter makes their remarks and moderate the discussion using those questions. The onset of the COVID-19 pandemic has placed a spotlight on the challenges facing older adults and the aging population, which have worsened as a result of the pandemic. Today, we're going to explore opportunities to improve the health and well-being of older adults. We're going to talk about the role that ageism has had in light of the pandemic or during the pandemic. We're going to talk about advancing healthy aging, elder justice, and equity. We're going to explore efforts to meet the needs of all Ohioans and all older Ohioans amid the pandemic and the health impacts of adversity and discrimination in older adults. And then last, we're going to talk about the role of caregiving in Ohio and and strategies that state and local partners can use to ensure that all Ohioans live longer, healthier lives. Today's presentation slides and other related resources are available. They're posted already this morning on the HPIO website and can be found by clicking the Events tab. And now I think we'll go ahead and start with our first presenter. And before we started this morning, we were just commenting that this is one of those instances where we're glad that we're using a virtual forum. I think most of Ohio is experiencing snow, and the East Coast is experiencing snow, and we didn't have any of the stressors related to getting our presenters here or our participants safely to Columbus for today's forum. Katie, we're very pleased to have you on this morning. Katie Smith-Sloan is the president and CEO of Leading Age and the executive director of the Global Aging Network. Katie, I'll let you take it away.
Great. Thank you so much. Thanks, Amy, and thanks to everybody who joined in, I guess, what is a snowy Columbus, Ohio. It's actually snowing here in Washington, D.C. as well. Really happy to have the opportunity to talk to you a little bit about ageism and COVID. And next slide, please. But first, let me just describe a little bit about Leading Age. So we are a Washington, D.C. based association of over 5,000 providers all over the country. Our providers are largely nonprofit, they're mission-driven organizations, some of whom have been in the service that they are in for over 100 years. So deep roots in community, deep roots in mission. We also have 38 state partners, Leading Age Ohio being one of our wonderful state partners. And we like to say that we represent the continuum of aging services. So our members are nursing homes, assisted living, home health, adult day, PACE programs, hospice, affordable housing, retirement communities, the whole panoply of services and supports that people may need as they age. But because aging is not a linear process, we actually are beginning to refer to ourselves as Lego blocks and accessing whatever Lego block is needed at any particular time in someone's life. Our core work is around advocacy at the federal level, education. We have an applied research institute in partnership with UMass Boston's Institute of Gerontology, whose purpose is really to inform policy and practice. We have a heavy focus on technologies that can help people age as well as help providers be more efficient and effective in their service delivery. The workforce, an issue that is a huge issue right now in our field. It has been for quite a while, and it cuts across all services, and then a number of other cross-cutting issues. So that's kind of who Leading Age is. So about 5 years ago, our board came together and did a relook at our mission and vision, and they declared at the time that our vision is an America freed from ageism. And they came to that after really long and thoughtful discussion about what's standing in our way of everything we believe in. And they concluded that that was ageism and how prevalent it was and pervasive it was. And we had a responsibility to begin to address the pieces of ageism that really impact our world the most. Next slide. So what is ageism? Well, it's the often unrecognized bias against older people and discrimination or even assumptions about people based on age. It's ubiquitous, it's universal, and it's global. As Amy said, I also serve as the executive director of the Global Aging Network, which is a network of provider organizations in about 60 countries around the world. And we have so much in common, so much to learn from each other. But we also are advocate at the United Nations with other non-governmental organizations. Next slide, please. And one of the things that the United Nations has recognized, as has the World Health Organization, is how widespread ageism is. And this quote that I put up here, COVID pandemic not only highlighted the vulnerability of older persons in emergencies, it witnessed cases of ageism and worrying accounts of human rights violations. So this is not a US phenomena, this is a global phenomena, and we all have a responsibility to address it. Next slide, please. You know, ageism is often perpetuated in the media, and I pulled out a few headlines, just recent headlines in the last month or so, which really underscore how these attitudes of about older adults and aging are perpetuated, but how prevalent they are. So read these. Welcome to Biden's Senior Center. Congress's gerontocracy problem. Democrats are too old. Gerontocracy again. Congress is too old. America is run by geezers. What were the founders thinking? So when you see these kinds of headlines and these kinds of statements in the media day in and day out, you realize how pervasive ageism is and how people are just taking it for granted. It's an is, and it's an is that shouldn't exist. Next slide, please. But it's also prevalent in other parts of our society, in public policy. The lack of an investment in long-term care, other than the pieces that Medicaid covers. We really have no long-term care system in this country. We have a lot of silos and disparate parts. In medicine, grossly undervaluing geriatrics and the lack of training in geriatric medicine, both for doctors as well as nurses and other clinicians. In philanthropy, less than 2% of philanthropic dollars go to support aging and aging-related organizations. In products, the prevalence of anti-aging creams and other kinds of things that are going to so-called fight aging, which I don't think you can do. Technology, companies are dumbing down technology for older adults. Certainly in advertising, the many pharmaceutical ads often have an undertone that's very ageist. And in Hollywood, Driving Miss Daisy just being one of many examples of how we perpetuate this notion of ageism. Next slide, please. So along comes COVID, and you know, ageism is still very much a part of the narrative related to COVID. We're frequently portraying older adults as vulnerable during this pandemic. And it is true that a large percentage of older adults have been impacted by COVID, as have others who have underlying health conditions. And certainly they have a greater propensity to become infected and even to die as a result of COVID. But it's an unabridged version of the truth. Older people are not just a homogeneous group of defenseless people in need of protection. First of all, they're not homogeneous. There is tremendous diversity among the older population, and they're not defenseless. But that is certainly how they're being portrayed. We also know through other research, particularly some done at Yale University, that for older adults, being exposed to or internalizing negative representations of old age influences their health, their mental health. It has tremendous health impacts on how they feel about themselves and their role in society. And that's just in a pandemic where we're dealing with all kinds of health issues, that exacerbates all of those other health issues. Next slide, please. We've also seen ageism in some of the public and other responses to COVID. Early on, from one state, the public health guidance was all those over the age of 70 need to stay home. So just picking an arbitrary age and saying, stay home. We've seen it in resource distribution, where hospitals got access to resources before long-term care, not at the same time as long-term care. And actually wearing my global aging hat, that has been true in Canada, it's been true in the UK. So we are not alone in how we have thought about resource distribution. We've seen it in treatment decisions, particularly access to ventilators. And there's much in the news about how Italy responded to this with, making sure that the ventilators went to younger people before they went to older people. And certainly in clinical trials, where we've had to really advocate hard to make sure that older adults were represented, well represented in clinical trials, which is usually not the case. And in fact, I think we were successful, although the data that's coming out now shows that people over the age of 85 were probably not well represented in those clinical trials. But I think we need to ask ourselves, would we be acting differently if COVID put young people as opposed to older people more at risk? If the first outbreak was not at Kirkland in a nursing home, but was in a college dorm, would our response have been different as a country? So, important question to ponder. Next slide, please. So how do we check ourselves against ageism in COVID? And I think I've thought about this a lot, and I think the answer to this is to demonstrate that we need policies and strategies that reduce everyone's risk. So we have a virus that is largely often asymptomatic and it's airborne. So community spread impacts everyone, not just older adults. Social isolation impacts everyone, as does resource allocation impacting everyone. So we need to think about fighting this terrible pandemic in the light of it's impacting everyone, not just older adults. Next slide, please. I also think we need to focus on the evidence of the value of wisdom, for example. If you look at our scientific leadership in this country, look at Dr. Fauci. Dr. Fauci is 79 years old. So because he's 79, he may be at higher risk, but he is not frail. He is not defenseless, and he is not vulnerable. So we really need to think about, what is he bringing to this? He's bringing the years of experience and wisdom to bear as he's addressing the nation around COVID. We also need to look at the wisdom that comes with intergenerational connections. And it's been especially true and heartening, I think, around COVID, when we've seen the wisdom of young adults and kids around technology coming together with the wisdom of experience of older adults, because technology has become the glue in many cases to social connectedness during this pandemic. So instead of thinking about dumbing down technologies for older adults, we're thinking about bringing kids and young adults together with older adults to learn technology together. We also need to focus on the evidence around the value of personal resilience. Older adults are showing agency during this pandemic. They're wearing masks, they're social distancing, they're isolating. Older adults are also connecting to one another by email, phone, and social media. I live in a neighborhood in Washington that has a very active village, which is basically a neighborhood association of older people that came together to make sure that they could stay in the neighborhood as long as possible. And this village has been connecting by email, by virtual events, by phone, by social media. These folks are maybe isolated in their homes, but they're not alone. They're connected, and they've done this all on their own. Nobody's doing it for them. But the older healthcare workers who have come out of retirement to volunteer on the front lines, doctors, nurses, and other clinicians in droves have come out, putting their own lives potentially at risk, but bringing those years of experience and wisdom to bear in a moment of crisis. I think there's been sort of a resurgence of mutual aid, and older adults are very much a part of that. Next slide, please. So we like to, at Leading Age, imagine what a world freed from ageism would look like, not just in COVID, but all the time. And we believe that would be one in which older adults, like people of all ages, are appreciated for who they are. That the wisdom and the lived experience that comes with age is valued. That intergenerational engagement is natural. That language, our language, is respectful and inclusive. You don't use words like gerontocracy and even senior. That age is a number and not a social value or a judgment. And I would add that something like geriatrics is as valued and prevalent as pediatrics. That philanthropic dollars would recognize the value of investing in aging along with kids and the arts and the environment and education. That we wouldn't talk about gerontocracies, but about talented public servants doing their job. You know, the most impactful antidotes to ageism based on the research that has been done is around bringing generations together. And I think that's definitely something for us to all think about in our work, but I think it's also really true. So thank you for your time, and I'm happy to answer any questions or turn it back to you, Amy.
Thank you, Katie. I don't see that we have any questions at this time, but if you would like to ask questions of Katie, please be sure to put those in the questions box. Right. Please remember to stand up, stretch. We'll be sitting for quite some time, so feel free to get up and move around as we continue on the webinar. Right. I think we can move forward with the program. Next up, we have Director McElroy, Director of the Ohio Department of Aging, and she will be joining us here shortly to give a presentation on updates from the state and the Department of Aging momentarily. Director McElroy, if you can unmute, you can start your presentation. Director McElroy.
Thank you. Thank you. Thank you for the introduction and allowing me to be a part of your forum today. It is truly an honor. And I'd like to offer my thanks to the Health Policy Institute of Ohio for being a valued partner to the Ohio Department of Aging. Your expert analysis and insight have been invaluable to helping us attain our vision that Ohio will be the best place to age in the nation. And I'd like to thank my fellow panelists for lending their voices to this important work, and to each of you in attendance for staying invested in the important issues. The Department of Aging has been working with HPIO for a little over a year to develop a prioritized specific action plan built on the foundation of Ohio's State Plan on Aging. Together, we have completed a clear assessment of the current state of aging in Ohio and developed a strategic framework that will ensure Ohio's aging network moves forward in concert to achieve goals that will improve the lives of all older Ohioans. Today, I'm going to tell you about how we work together to create Ohio's Strategic Action Plan on Aging, what it contains, and how you can act on it. I'm proud and excited to announce that the Strategic Action Plan on Aging, or what you will hear us refer to as the SAPA, will be released to the public very soon. It is a prioritized plan to advance elder justice and equity and achieve optimal health and well-being for older Ohioans. It is built upon the absolute truth that aging is a universal experience that should be valued and celebrated. The goal of the SAPA is that all Ohioans live longer, healthier lives with dignity and autonomy, and disparities and inequities are eliminated. The SAPA vision is the same as that of the Department of Aging, that Ohio is the best place to age in the nation. This means ensuring that Ohioans live longer and extending Ohioans' healthy and active years. But before I go into the strategies and objectives of the plan, I want to briefly describe what we learned while we were creating it. In June of this year, we published the Summary Assessment of Older Ohioans. This report provides a comprehensive picture of the health and well-being of older Ohioans that informed the development of the SAPA, and it was designed to answer two main questions. The first, what are the biggest health and well-being strengths and challenges for older Ohioans? The second, which factors that impact the health and well-being of older Ohioans are most important to address? First, Ohioans, what we learned, face the consequences of both historical and contemporary injustices fueled by continued ageism, ableism, racism, and other forms of discrimination and oppression. As a result, the opportunity to live a long, full life is out of reach for many Ohioans. Second of our notable findings, Ohioans living just miles apart, both in urban and rural communities, experience strikingly different life expectancies. Shorter lifespan is driven by community conditions and access to resources such as education and income, and disproportionately impacts Black Ohioans and Ohioans with a disability. We also learned that half of Ohio renters over age 65 spend more than 30% of their household income on housing costs, which leaves them fewer resources for necessities such as food, medical care, and social activities. It's also important to note that mental health and addiction issues persist in our state, and older adults are not exempt. We also confirmed that older Ohioans face a lack of caregiver supports and a healthcare workforce that lacks the capacity to meet their needs. And finally, we found that chronic conditions, including heart disease, dementia, and related disorders, were among the top 10 causes of death for older Ohioans. What we know from the summary assessment is that Ohioans face significant challenges to their health and well-being. And these challenges will require a concerted effort across aging network partners and beyond to address. Equity, where all older Ohioans live to their full health potential, is only achieved by addressing these underlying drivers of poor health. And this brings me to the SAPA. Despite the challenges they face, older Ohioans make substantial contributions to society, including working, volunteering, caregiving for young children or other family members, and serving as community leaders and mentors. Often these contributions go unrecognized and are uncompensated. The SAPA strives to correct this by ensuring all Ohioans have the opportunity to live with dignity and autonomy no matter where they live. We developed this plan with the assistance of the Health Policy Institute of Ohio and the input of multiple stakeholders. And this included a 71, that's correct, you heard me say a 71-member multi-sector advisory committee. 19 key informants representing area agencies on aging and other organizations serving older Ohioans most at risk for poor health outcomes. And leadership from the Department of Aging and our state agency partners, including the Departments of Health, Medicaid, mental health and addiction services, job and family services and transportation, as well as the Ohio Housing Finance Agency. The SAPA emphasizes the need for systemic change to achieve elder justice and equity, which will require fostering and promoting systems, policies, and beliefs that value aging and dismantle ageism and other forms of discrimination. There are 6 topics and 15 issues prioritized in the SAPA, and strategies and objectives are organized around these priorities. These topics are livable communities, prevention and self-management, services and supports, social connectedness, population health, and preserving independence. And the overall approach of the SAPA is built upon the core principles that you will hear me say again and again: elder justice and equity. So how will we implement and act on the SAPA? Well, we know that achieving the SAPA goal and vision will require collaboration among a wide range of public and private partners at the state and local levels. All Ohioans and organizations across public and private sectors will have a role to play in advancing elder justice and equity by first creating an age-integrated society that removes barriers and provides the necessary services and supports for older Ohioans to live long, healthy, and productive lives. We must also foster and promote systems, policies, and beliefs that value aging and dismantle ageism, racism, and other forms of discrimination. And we must tailor strategies and allocate resources to older Ohioans with the greatest need. The menu of strategies in the SAPA provides flexible options that rural, suburban, and urban communities can collaborate on to improve outcomes for older Ohioans. The plan also includes a list of national and state-based resources that provide additional guidance and information on ways to impact these issues. State and local partners in the public and private sectors can act on the SAPA by advancing elder justice and equity and implementing one or more of action steps. These include align with and focus on one or more of the 15 issues and 8 priority populations in the SAPA. Advocating for funding and policy change to address SAPA issues. Fund evidence-informed strategies identified in the SAPA. Implement one or more of the evidence-informed strategies identified in the SAPA. Partner and collaborate within and across sectors to improve SAPA outcomes and evaluate the progress on SAPA objectives and the impact of SAPA strategies. And once the SAPA is finalized, this will be posted on our website at aging.ohio.gov. You'll be able to read the full document and also have access to a quick guide that will provide a high-level compilation of SAPA priorities and evidence-informed strategies for easy reference. So I invite you and implore you to join us on this journey. Now I want to take the next few minutes I have to address COVID and older Ohioans in our state. When we started developing the SAPA, we knew little about the unprecedented changes, challenges, and unfortunate tragedies that we would soon face as a state and a nation from the devastating effects of COVID-19. It is not an overstatement that this pandemic has been the most significant, traumatic, and arguably the most important public health event to hit the United States and the long-term care industry in more than a century. The disease took aim at our older adults, and it has not let up. It threatens their health, their needed services, their living arrangements, their interactions with loved ones, and their lives. And unfortunately, older Ohioans and their cohorts throughout this nation have been disproportionately impacted by this disease in mortality and morbidity. We have called upon our legislature and our federal partners to pass legislation and issue guidance that help us manage the pandemic outside of the traditional space and respond to situations unlike any we have witnessed before. Throughout the pandemic, we have balanced the need to save lives with the need to preserve quality of life. It has not been easy. There have been sacrifices and trade-offs, but because we've relied on the guidance we've received from our state, our federal, our local partners, and stuck with our 4 values, we have saved lives. We have followed 4 guiding principles in making policy decisions. First, we've used a phased approach. As we've reopened various settings to visitors, we've done so gradually, building on our successes and learning when things didn't work as we had hoped or where things worked well. Second, we've relied on preparation to do things the right way. Third, we've had the flexibility in every step and every move. We've balanced state and federal guidance and listened to provider associations, industry representatives, families, and advocates. And finally, we have strived to be transparent at every juncture within this state. We've gathered data and we make it available to the industry, to the media, to families, advocates, and more. What we know is that COVID-19 revealed many things to the world. It put on the stage our systems that were intended to protect and preserve life. The pandemic has also cast a light on ageism in America. As a society, we still see age, illness, decline, and death as inextricably linked. And for the sake of those lost and those at risk, we must remain vigilant, understanding that health disparities, chronic conditions, access to care, social determinants of health, technology, all of these things must inform our decisions, and they inform the policy within the DeWine administration. If anything, the pandemic has only amplified our call to action. And the world is watching us now, watching us as an aging network, watching us as a country. It has shone a bright spotlight on significant inequities, and now is the time to face them, embrace the need to change, and accelerate the evolution of long-term services and supports in Ohio and across our nation. We can change that, we must change that, and we will change that. COVID is the wake-up call to start addressing social determinants or community conditions across one's lifetime. We will be remiss if we come out of this pandemic and have not rigorously re-examined how the social needs early in life affect us in later life. It is a reminder for some and a wake-up call for many to appreciate healthy living across one's lifespan. Because healthy aging is not simply a destination or a point in time where we begin to have the conversation about disparities. The SAPA gives us the framework to collaborate and cooperate at multiple levels throughout the state to examine these things and to change lives. We simply can't accept things as they were. We cannot go back to business as usual. If we do the same things post-pandemic that we did pre-pandemic, then we, as an aging network, as a state, as a nation, we will have missed our moment for change, for transformation, and for growth. So please join me in our mission. Always work to change how people think about aging and older adults. Let's make Ohio the best place to age in the nation. This is not solely the responsibility of the Department of Aging or the Aging Network alone. This is a societal issue. This is a community issue. It is a personal issue. On behalf of the Department of Aging and Governor DeWine, I look forward to working with you to write this new, exciting chapter for aging Ohio. And I thank HPIO for giving us the tool to put us on the right path. Thank you.
Thank you very much, Director McElroy. It's been a real pleasure for HPIO staff to work with the Department of Aging on development of the staff. I think it's a really dynamic document that's going to help a lot of people. I do have a question that came in the question box from somebody that's listening in. They want to know, when will the SAPA report be released? And they also want to know, does the report address any racial disparities in nursing facilities? And if it doesn't, the person would like to know if there's any resources or sources of information where they could find out about those racial disparities in nursing facilities. I'm sorry, Director.
You're muted.
Pardon me. In terms of the release date for the SAPA, I will rely on our partners here at HPIO. They've been working really closely with key staff within the Department of Aging. And so I rely upon HPIO and my key staff to determine when that official release date will be set. I know that I am eagerly awaiting. I know that everyone who has an opportunity to review the SAPA, I believe, will be very pleased. And so I guess I'll defer to our partners here who are also on the line from HPIO if they want to weigh in on that. With respect to equity within facilities, we're going to be very focused on equity across the aging network. And that can mean a lot of things. Certainly, race is one factor, but it will not be the only factor. We're certainly concerned about any areas where equity could have an impact on access to service, quality of service, types of service. And so certainly we're going to be very locked into that, both in the facility space, but also within the home and community-based services space as well.
Thank you, Director McElroy. And when the SAPA is released, then we will be happy to make sure that you all have that information and know that it's available on the Ohio Department of Aging website. All right, and thank you for being here with us today. We really appreciate your time.
Absolutely, thank you so much. And again, thank you for the incredible work and helping us to have the tools we need to be on the path for this very aggressive but important work that we intend to take on with the assistance and collaboration of so many others. Thank you.
Thank you. I believe that's all the questions we have for the director at this time. We did have a few questions come in for Katie over the last few minutes. So Nick, if you want to ask those questions to Katie, and Katie, if you can turn your camera back on, we'll be able to get a few questions to you.
Yeah, there's a couple of questions directed at Katie. The first one is the person wrote that there's a section of the older population at great risk of complications and death due to COVID-19 as they're being infected in long-term care facilities. So the question is, how would you recommend state and local government and public health address this specific subgroup with messaging? So again, a messaging for the folks that are in long-term care facilities with the risk of COVID-19.
Well, thank you for the question. I think it's absolutely the case that long-term care communities have been hit hard by COVID. And, it's a function of the virus itself and the circumstances. When you've got a number of individuals with underlying health conditions living in a congregate setting with a virus that is airborne and often asymptomatic, and with 3 shifts of staff coming in and out every day, and with the virus raging in the broader community, it's in many ways no wonder that we've seen the kinds of cases that we've seen in long-term care facilities. And I think what's really important to understand is the nursing homes and assisted living didn't create the virus. The virus is out there in the community. And nursing homes for years, for decades, have had infection control procedures in place. They've focused on, the highest quality of clinical care that they are paid to deliver. And so I think, I commend the homes for the great work that they're doing. And I know there's, a lot of grief and suffering going on, but it's going on outside the homes as well. So, and we're coming out of this, we will learn a lot about the importance of single rooms, for example. We'll learn a lot about workforce retention. And, one of the things that we learned early on with Kirkland is that there were staff that were working in multiple nursing homes. And that's really a function of how we value or not the workforce that works in there. So we have a lot to do coming out of this. But there's been just amazing heroism and commitment and compassion on the part of those who work in nursing homes that I think we can't overlook.
Great, thank you. One other question regarding Leading Age's work to kind of combat ageism. The person wanted to know if you've collaborated with other organizations, like the example they gave was the Gerontological Society of America. So have you collaborated with other organizations, and has this effort been evaluated with respect to its effectiveness? And then the final part of their question is, besides intergenerational connection, which you mentioned, what has been found to work and what has not in terms of battling ageism?
So let's start with the first part
It's
of that question,
yes.
which is, yes, we are collaborating with a number of other organizations, both the other nonprofits who are involved with our work at the UN, but also in Washington, there's an organization called Frameworks that did some work on reframing aging, and really focused on how do we reframe ageism, and Gerontological Society is part of that. So is the American Society on Aging, Grantmakers in Aging, AARP, NCOA, and others. And so we're very much a part of that working group to take the great work that Frameworks did and push it out into the community and making some of that language more normative. So that is definitely a great collaboration with us. In terms of how to have an impact beyond the intergenerational, I think it's, a lot of it is just raising awareness of how prevalent ageism is. So I know even on our staff at Leading Age, as we began to talk much more about ageism, there were so many aha moments where we realized that the language we use, the sort of the assumptions that we have are in many cases ageist. And so just that awareness raising is, I think, where we need to start. And that needs to happen everywhere, not just at Leading Age.
I just want to pop in. This is Amy Rowley McGee, and I want to particularly thank you for that remark, Katie. That's one of the, we've thoroughly enjoyed working with Director McElroy and her team at the Ohio Department of Aging in preparing the summary assessment and partnering with them and many other stakeholders to create the SAPA. But that, I think I personally have had many of those aha moments. And I think others on our team have, and it's something that we're all, I think, growing in and continuing to learn about. But I don't think we would be I don't know that we would have embarked on that journey without the opportunity to partner with the Ohio Department of Aging. So I guess I just want to encourage everyone that's on today that we all have to start somewhere. And even if you've realized that you've had some, that you've stepped into this in the past with an ageist lens, there's always the opportunity to improve in the future.
That's a great point.
All right, are there any more questions, Nick or Alana, or should we move on to Kim?
We are good
No
to
more,
go.
no more questions. Yep.
All right, great. Well, thank you. Thank you to both Katie and Director McElroy for your fabulous presentations this morning. And now we're going to move on to Kim Keel. Kim has been with the Ohio Department of Mental Health and Addiction Services for a number of years, I believe, Kim. I've known Kim now, I think probably almost 20 years. He currently is the Trauma-Informed Care Project Coordinator at OMAS. Thank you for joining us, Kim, and we'll hand it off to you.
Great, thank you, Amy. And I want to thank HPIO for allowing me and inviting me to be a part of this presentation with Katie, Director McElroy, and with Holly. I'm humbled, and my first words are thank you. And that is thank you for what you have done in terms of teaching me about the intersection of trauma and adversity and health discrimination through my journey with my dad, who has gone through a system of care and who ended his journey about 2 weeks ago in a long-term care facility. Was not COVID related. It was natural aging process. So thank you for what you do. Thank you for the work that you perform on behalf of older adults. It's pretty incredible, and I'm humbled to be here to sort of share our personal experience with that and how all of this sort of intersects. So some of the stuff that I'm going to share has already been shared with through Katie and through the director, and I'm assuming probably with Holly too. So I think I'm going to have you advance the next slide. Next one. All right. So I want to spend just a few minutes talking with you about sort of this intersection between trauma and discrimination and racism and adversity, trying to connect this all together. We have longer trainings that we do around the impact of trauma, particularly trauma-informed approaches in responding to older adults. And so we know about how this impact or this focus on trauma has really shifted from what happened to you, from what's wrong with you, to really what happened to you, and not just about what happened to you, but what's happening to you now. Many of you, I'm sure, are familiar with the ACE study, and the ACE study was a pioneering study that occurred back in the early 1990s and mid 1990s that looked at 3 areas of adversity: abuse, neglect, and household dysfunction, particularly in younger children, and realized that for children who had experienced those adversities of abuse, neglect, and household dysfunction, the more of those adversities that they experienced and the longer that they experienced, there was a direct correlation for an increased risk of all kinds of things later on in life. And you see some of those there, particularly as it manifests itself in physical outcomes later on in life. That study has been replicated hundreds and hundreds of times on all kinds of populations. And recently, some of the research has been done around not just the adversities of what older adults had experienced maybe as children or young adults, but certainly some of the adversities that they experience in the aging process. Next slide. So we know that there are some profound effects. So if we think about an older adult who may have had some adversity in early childhood, and now they start to experience some of the effects of discrimination, both everyday discrimination and major discriminatory events, we know that they begin to start to have now yet another impact on older adults. And those impacts often are related to health outcomes, and how that manifests in the need for care. Next slide. So in the Healthy People 2020 report in Social Determinants of Health, in particular, they talk about 5 place-based domains. And those domains are economic stability, education, health and health care, neighborhood and built environments, or where people find themselves, and social and community context. And within that is this notion of discrimination, and how does that impact? And this is no news to anybody, particularly on this forum. However, we're starting to begin to pull this together. So if I am an older adult who has experienced some adversity as a child, and now I'm growing older, and I'm starting to experience these discriminations, everyday discriminations, such as being treated with less courtesy, receiving services different than other people, or I might have a singular event that includes losing a job. And as an older adult, I might still be very capable in terms of working and participating and contributing. And so now I'm starting to have yet these other impacts on my health. And so therefore my need for service continues to grow. Next slide, please. And sometimes those activities result in a limitation of how I'm able to participate in my own care, how I'm able to participate in the treatment of other people who are providing care. And it may contribute to sort of these new ways that Katie in particular talked about the role of technology. I can tell you that we tried desperately, you know, much like many of you are experiencing, maybe personally or in what you're doing, you know, for the last 9 months, our relationship with our dad really changed. And we tried very, very hard to get him to understand technology. And that just wasn't going to be part of what he wanted to do. His reaction to that, as we tried the first time, and we learned that probably not having all 9 grandchildren, his 4 children, and him on a Zoom call all at one time is probably not the first way to introduce the use of technology. So as I mentioned, I'm so thankful to be able to sort of live part of this as I share this connection between trauma, discrimination, aging, and racism. Next one. So we know that there are specific traumas that occur in older adults, right? The loss of spouse and peers, just the process of aging and some of the chronic and life-threatening diagnoses, increased dependence on someone else. And again, we were able to watch all of that happen with my dad. And these are all 2 familiar things with what you do in terms of your service provision to older adults. So we have an individual who may have experienced these adversities of abuse, neglect, and household dysfunction. We have an individual who now is growing older, and in that growing older are experiencing things that might be traumatic, right? And how does that manifest itself? Next slide, please. So here's a list, and I'm not going to read all of these. The PowerPoint is going to be available to you, but you know these things. You know about how oftentimes as older adults manifest these reactions to trauma, their reactions to things that may be triggering, that may bring up some of the traumas that they've experienced throughout their life. Oftentimes we see these things manifested in older adults, and sometimes that looks like non-compliant or treatment resistant or stubborn or whatever in case notes, right? When in fact, this is just us beginning to figure out not only what's wrong with you, but what happened to you. and what is happening to you now. Next slide. And so if a person is an individual who has experienced trauma and they try to seek help, and that particular agency doesn't understand the value of asking what happened, we know that sometimes that person is blamed or they're labeled, and so therefore they experience more trauma, and it becomes a very vicious cycle. Next slide. So I don't know about any of you, but I was a person who never really read Catcher in the Rye or War and Peace. I always used the Cliff Note version. So here's the Cliff Note version. So we have these adversities as a child. We know that it impacts us both in terms of health risks and neurological, the way our brain functions, the way we think, the way we make decisions, and that then can contribute to long-term health and social problems. And then we add the aging process and the process that comes along with that and some of the traumas that occur with that. Next slide. And I so appreciate everything that has been shared so far. So now we have all of that, and now we have this thing called COVID. And we have this experience now of this collective trauma. Judith Herman, in her work back in the early 1990s, in her book Trauma and Recovery, suggests that among the things that happen to people who experience trauma, not all, but some people, they have this disruption in a sense of control, connection, and meaning. And we know the complications that arise where if I already am experiencing this disruption of control, connection, and meaning, it's now compounded by COVID-19. Next one. On top of that, we experienced this renewed focus on racial and social injustice and the things that go along with that. And if I am a person who has experienced that as a younger adult, and now I'm growing older and I'm seeing these things on the news, certainly if I'm in a place and I'm in a system or a service provider who doesn't understand the impact of trauma, they're going to start to see my ability to communicate this is making me feel uncomfortable. Next one. And of course, Katie and the director really talked about how, and we know how COVID is really amplifying racism because of how it is impacting folks of different backgrounds, African American, Latinos. We know that exponentially it seems to be showing up, and it's not seemingly, it is showing up differently and more pronounced in those populations. Next slide. So this is what it looks like, right? This is what it looks like in the world of us trying to provide service to older adults who, as we begin to understand not only the value of what happened to them, but what's happening to them, and then we have all this other kind of stuff that's going on. Organizational stressors, our own staff stressors, us as people who provide those care, and the stressors that are happening to the people that we serve. Next slide. So SAMHSA, the Substance Abuse Mental Health Services Administration, suggests that there are dimensions of wellness. So now we understand this. What are we going to do? And like I said, this is just a sort of a Cliff Note version of a deeper dive training that we certainly can make available to anyone who might be interested in how you look at a trauma-informed approach in responding to older adults. And SAMHSA has identified these dimensions of wellness, including occupational, intellectual, financial, spiritual, all of those things that we know contribute to a person's feeling better about themselves, feeling as though they have a sense of control, connection, and meaning. Next one. So what are some things that help in healing and working with people who have experienced trauma and adversity. We know that it impacts a wide range of the human experience, and that we can promote self-assurance by reminding older adults that they really survived a painful experience. And in that, being able to identify those things that help them to become resilient and to be able to continue in their participation in their own care and in their participation of the family unit or the care unit, however that defines itself. And there are ways creatively that we can have older adults share their reactions and how those experiences impacted them. Next slide, please. And that sometimes the reactions that we're having are really normal responses to a very abnormal experience. And it doesn't take too long for us to recognize our own reactions and experiences to COVID, let alone outside of being in the older adult population. Promoting a sense of their own hardiness and the things that they're able to do and how they get up every day and continue. Next slide, please. So I think it's really important that staff who provide in-home or day programming or residential programming understand the prevalence of trauma and its impact not only on the body but on our way of thinking and the way we process things and our own development, that we can find safe and helpful ways to inquire and assess for trauma. And it doesn't have to be the ACE questionnaire, it doesn't have to be a specific trauma screen, but there are ways that I'm sure agencies are already collecting this information, but oftentimes we don't sort of sit down and kind of look at what that information, because oftentimes it's housed in different pieces of a case file or a case record, and that we can really respond to by implementing trauma responsive practices. Next slide. And that this can lead to not a vicious cycle, but a new and virtuous cycle. So a person experiences trauma or chronic stress or adversity, they seek help, and us as a service system, however that system is defined, whether it's the family providing the service, whether it's a provider coming into the home, begins to start to ask the question, what happened to you? I think about one of the people that we often use in our training who is an older adult, and his history of his childhood abuse and neglect, no one for 79 years of his life had ever asked him what happened to him. They always reacted to what was wrong with him and looked at and provided resources based on a diagnosis instead of asking the question. And so since that time, he's been able to understand, and the people who provide service to him provide it in a very different manner because they understand him now. And he's like one of our trauma-informed care champions that we often bring around with us. And he's very, very keen to want to share his story because someone finally took the time to ask him what happened to him and be able to understand what his experience was in his journey. And so because of that, the services that are provided to him kind of mitigate and don't re-traumatize him. And he's able to tell that story, and that really we can begin to enter into those therapeutic relationships that make things work better for people, and that we don't all have to be therapists to enter into that relationship to be therapeutic with people. Next one. So here are some resources that we've identified: the Ohio Care Line, who are trained clinicians available 24/7. If anybody has a question related to COVID and the things that they're experiencing, all you have to do is call that number. I've listed our website around trauma and trauma-informed care. I would draw your attention to the Wellness Project. Wellness Project is a very cool resource available. In that Wellness Project, we have resources around breathing practices, mindful movement. We don't call it yoga because I think yoga conjures up like, for me, it makes me nervous. Like I'd rather be involved with mindful movement. There's resources on meditation, and there are some other spiritual resources there as well. Among the resources that I provided to HPIO that are on the website is a resource called the Trauma Informed Organizational Change Manual. It's from the College of Social Work at the University of Buffalo. By far one of the best documents. We've looked at tons and tons of resources that actually walk an agency or a service provider, like, how do I do this differently? How do I become more trauma responsive, more trauma sensitive? So that's posted on the website as well. Next one. Here is my contact information. If you are interested in a deeper dive training for your agency, we'd be more than happy. And we're working with the Ohio University and the Department of Agency on, we have some curriculum that we've already developed that certainly we can make available for training for anyone who wants to know. Last slide. And here's all of the ways you can get a hold of us. I have no clue what any of those are, other than the website. I'm sort of like my dad, technologically challenged. So thank you. Again, thank you for what you do. Thank you for allowing me just a few minutes to come and talk about how we can connect the impact of trauma, adversity, and begin to understand how we can provide services a little bit differently that really can impact the health outcomes of older adults.
Well, thank you so much, Kim, for your presentation and for sharing your personal experience with your dad over the last several months. I'm very sorry to hear of his death, but I appreciate how you related that to your remarks today. I don't see any questions in the question box. Somebody did say, thank you, Kim, fantastic information. We'll make sure that we post those resources that you shared at the end on the events page of our website so that others can access those. I think that toolkit that you mentioned from the College of Social Work in Buffalo, was it? Is that?
Yes, one of
That sounds
the best tools, because quite frankly, it helps you measure what it is you want to do to become a little bit more trauma. It measures you along the way. You don't have to do a pre and post test. It has measurements along the way that just like, oh, I get it now. So what does a trauma-informed policy look like? What does a procedure look like? What does a protocol look like? It's by far one of the best tools that we've found, quite frankly.
That sounds wonderful. And I know we have a number of providers or managed care organizations or area agencies on aging on the webinar today. So it sounds like that would be a great resource across the board, across all of those sectors. So thank you, Kim. I think we'll move on now to our final presentation for the day, and that is Dr. Holly Holtzen, who is the State Director for AARP Ohio. And again, be thinking of your questions as we go along. Go ahead and type those into the question box. Remember to stand up, stretch. I've had my little weights here with me, and I've stood up periodically and done a few reps. So feel free to do that to keep yourself engaged. Good morning, Holly, or actually good afternoon, Holly. Thank you for joining us.
Oh, good afternoon, and thank you so much for inviting us to this really important webinar. I've really enjoyed listening to all of the presentations and our other speakers this morning, this afternoon. So I wanted to first start off and to say a little bit about AARP Ohio. AARP, with 1.5 million members in Ohio, is a nonpartisan, nonprofit, nationwide organization that helps empower people to choose how they live as they age. We work to strengthen communities and fight for issues that matter most to families, such as healthcare, employment, income security, retirement planning, affordable utilities, and protection from financial abuse. So today, what I hope to cover is both just touching on long-term services and supports with a clear focus on family caregiving, and talk about some data resources that are available to the public through our AARP LTSS scorecard and the caregiving dimension within that, and briefly touch on some policy options here in Ohio, but then broader, throughout the country. And then I would be remiss if I didn't talk about the COVID-19 implications, both in nursing homes and some policy solutions. And it's really, Director McElroy did such a great job talking about this and what this means. So hopefully we'll be able to end on a good note and talk about all of the opportunities moving forward and what we can learn from this period of time. So LTSS, consists of a broad range of day-to-day help needed by people with long-term conditions, disabilities, or frailty. And this includes personal care such as bathing or dressing, to the more complex care such as wound care or medication assistance. It can include housekeeping, transportation, paying bills, and really keeping those connections with ongoing social services. And LTSS, is provided in the home, but it's also provided in other settings, such as assisted living settings and other supportive housing settings, even in nursing homes. And LTSS includes not just supportive services, more formal services, but it's also what's provided by family members and other unpaid caregivers. The increase in prevalence of caregiving really does mirror the face of caregivers. It's up among all racial and ethnic groups, educational levels, work statuses, genders, and nearly all generations. And this increase in prevalence that we're seeing is due to a lot of factors. The aging of the baby boomer population requiring more care, limitations or workforce shortages in the healthcare long-term services and support systems, increased efforts by states to facilitate home and community-based services, certainly, and increases in the number of Americans who are self-identifying that their daily activities are in support of their family members or friends with health or functional limitations. And then it's really the confluence of all of those trends together. So across the country, we have about 53 million caregivers, and that's 1 in 5 Americans. There we go. So in Ohio, we have an estimated 1.5 million family caregivers that are providing care at some point in time in the year. And what this equates to is an annual value of $16.8 billion in unpaid contributions to our long-term care system. So generally speaking, family caregivers, what do they look like? So 6 in 10 report working while they're caregiving and and 61% have experienced one work-related impact due to caregiving. 32% provide at least 21 hours of care a week, in addition to working full or part-time in their job. And a little over half of caregivers really expect to be caring for someone over the next 5 years. The Harvard Business School shows that nearly 1 in 3 workers have said they've quit their jobs for caregiving responsibilities. And while I don't have data on it today, we know that during this pandemic, impact on women in the workplace has been significantly impacted. So what I'd like to share with you today is the AARP Long-Term Services and Support Scorecard. And before we get into what the data says, I just want to provide a few caveats and some information about what it says and what it does not say. So the scorecard is really a multidimensional approach to measuring LTSS performance within 5 domains. And the 5 domains are on your screen. So affordability and access, choice of setting and provider, quality of life and quality of care, support for family caregivers, and effective transitions. What this does not say is how well states or communities are managing COVID-19. It does not have measures that are directly relevant to COVID, preparedness, impact, or response. The 2020 scorecard, the data was collected before COVID came to us. And it was also analyzed prior to the outbreak. So in addition, currently available data about COVID are not complete, nor are they consistently comparable across states. So, we're working through some of those measures, and I'm going to touch on what we do have in this period of time. So the goals of the scorecard are to really raise the national level of performance for LTSS and to help states assess LTSS across multiple dimensions, the 5 dimensions I've mentioned, measure their progress, identify areas for improvement, engage the public and private sector, such as what we're doing here today, and really, at the end of the day, improve the lives for older adults, people with disabilities, and family caregivers. The scorecard can be used by state administrators, stakeholders, and others to better understand their state's performance and really pick up the pace on creating and sustaining a high-performing system of care for older people and adults with disabilities. So the overall ranking, to get into a little bit of the data, and all of this is available online on the AARP website. Ohio's ranked 19th, and that is our 2020 ranking. And below, you'll see the number of indicators for which Ohio ranked in the top quartile, second, third, and then bottom quartile. And then you can also see in the map where we are in relation to other states. What I'm going to focus on today, like I said, is the caregiving dimension. This is the one domain where we have not made as much progress as we have in other domains. And really, support for family caregivers is so important to our system. This next slide provides the rank, the number of indicators with trend, and whether we've made substantial improvement, no change, or had a decline. And we haven't seen a decline in the scorecard measures, but there are quite a few areas where we're just not seeing substantial change. So I hope you can see this okay. I was trying to take some screenshots of the scorecard, and you can pull up any state. This is for Ohio. It'll show you kind of the baseline, the data year, the state rate, the data year for the 2020 scorecard, and the rankings. And this also gives you a little sense of what's included, what indicators are included in the scorecard. And then there's indicators here. This arrow across page means there's no change. A check mark means there was change in performance. And like I said, we didn't have a decline. So what you will notice is we did have a change in performance on this dimension of person and family-centered care. We did have some CARE Act legislation passed in 2017. So that's extremely positive, but we haven't made progress on any of these other indicators. So some policy options. Like I said, we made some progress in 2017, but we really need to focus on some meaningful change in these other areas in terms of caregiver support. Options that are out there, caregiver tax credits, which has a lot of support, and there's a graph on, I guess, your right-hand side showing how helpful these policy options could be. And really the caregiver tax credits to cover those out-of-pocket expenses that caregivers are taking on upon themselves to care for their loved ones. Another option is expanding the scope of practice for advanced practice nurses. So throughout Ohio, we have many areas where there are shortages in primary care providers. And within the scope of their license and their advanced practice training, nurse practitioners could fill some of those gaps to address those shortages. Expanding access to telehealth. So telehealth has become very important during this pandemic, but it is very helpful for caregivers. Caregivers can engage in the conversation. It obviously cuts down on traveling. And if you haven't engaged in telehealth during this pandemic, I highly recommend it. I've done it as early as this morning, and it does provide additional access. And then lastly, expanding paid family leave options for caregivers. So I'd like to turn to the COVID-19 implications quickly. As you know, I think Director McElroy mentioned and Katie Smith-Sloan, it has been absolutely devastating on nursing home residents. Over 106,000 nursing home residents and staff have died from COVID-19 nationwide. Here in Ohio, the most current number as of December 9th is 3,700 individuals. And this data is provided, and I included a slide just to show you what the ODH dashboard looks like. It's updated every Wednesday to provide information to the public about what's happening. So during this pandemic, and because the LTSS scorecard doesn't address COVID at all, has nothing to do with COVID, AARP and their wonderful research staff and our partners have put together the AARP COVID-19 Nursing Home Dashboard. This data is data from the Centers for Medicare and Medicaid Services, which is self-reported by nursing homes. And the dashboard was then developed by AARP Public Policy Institute in collaboration with the Scripps Gerontology Center here in Ohio. And what it provides are 4-week snapshots of the virus's infiltration into nursing homes and the impact on nursing home residents and staff. And this dashboard is available at the website that you see on your screen. And it is updated every 4 weeks. And I believe we're on our 2nd or 3rd version. So the December findings, in the 4 weeks ending November 15th, nursing home cases and deaths reached the highest levels since reliable federal reporting began in June. Nationally, rates of COVID cases among nursing home residents and staff doubled from the previous dashboard reporting period. And we're really calling on Congress and the states to take further action to reverse these trends. to ensure we have transparent reporting, adequate staffing, and sufficient PPE and testing to keep the nursing home residents and staff safe here in Ohio. So I did include a couple just screenshots to give you a sense of what's available from the nursing home, the COVID-19 nursing home dashboard. There are mapping capabilities so you can compare across states and the national average as well. And so this snapshot is nursing home resident deaths per 100 residents. And then I've also included the staffing shortages. And if you remember, this is CMS data self-reported by the nursing homes. And they're self-reporting that almost 37% in Ohio are reporting a shortage of nurses and/or aides. And I think one of our earlier speakers, either Director McElroy or Katie Smith-Sloan, mentioned that workforce issues are really being amplified right now. Additionally, almost 30% of facilities have self-reported that they are without at least 1 week supply of PPE. And most nursing homes have PPE except for the N95 mask. And this is the item that's really driving the high number of PPE shortages here in Ohio. I would also note this data includes hand sanitizer, even though it's not considered PPE. So, what are some solutions? We really need to prioritize regular and ongoing testing and PPE, like I said, for residents and staff. But in addition to any inspectors, ombudsmen, and visitors to the nursing homes, really improve transparency, focused on daily public reporting. Communication with families is extremely important when you're talking about discharges or transfers. And then accountability for state and federal funding that goes directly to facilities. I think this was mentioned earlier, but visitation and staying connected to your loved ones in nursing homes is so important, and there are a lot of barriers to that right now. I think Kim mentioned how, getting on a Zoom sometimes works, sometimes doesn't. But families need access through facilitated virtual visitation. And then establish some timelines, some milestones, and accountabilities for those facilities that have resumed in-person visitation. We're also fighting to ensure quality of care, like I said, through adequate staffing, oversight, and access to in-person formal advocates through the Ombudsman Office. And then lastly, AARP rejects immunity for long-term care facilities related to COVID-19. And in the state of Ohio, we've been able to narrow the scope of that, but civil immunity was passed several months ago. So before I close the presentation, I think ending on something positive, what the pandemic has taught us is obviously we have a lot of opportunities to rethink how we provide long-term care, how we provide nursing home care, and really reimagine the system, whether it's single rooms, maybe a totally different model of providing nursing home care. And I think both Director McElroy and Katie Smith-Sloan mentioned really re-examining our entire system and using this as a wake-up call to positively move forward and learn from this horrible tragedy. And I think there's a lot of things that we can do to improve the lives of our loved ones, our caregivers, and move forward. So I appreciate the opportunity. I think we're a little over time, so I apologize. And thank you, HPIO and Amy.
Oh, thank you, Holly. And yes, we have just come a little bit over the concluding time for the forum, so I don't think we'll take questions. What we might do though is follow up. There are a couple of questions in the question box, so we may follow up with our speakers and those folks who've posted questions to see if there's any responses that the speakers would like to provide. We appreciate everyone who stayed with us here to the end. I think we're all coming away with some potential action steps we can take individually, in our organizations, and then also some policy opportunities. I would like to encourage everyone to engage in the policymaking process, to make sure that our legislators and others who represent us in elected or appointed offices know the perspectives of people living in Ohio on these issues. We'd like to invite you to just take a very brief survey here rating the quality of today's online forum. There will also be a more in-depth survey that will come out shortly after today so that you could provide additional feedback about today's event. Thank you again for attending today's webinar, staying with us until the end. Please be safe, and we hope to see you all face to face sometime in the new year. Take care. Bye.